Thank you. Good evening or good afternoon, everyone. I'm Maninder Kalkat. We met yesterday uh, in the thoracic sessions, and this is the last talk. And I promise I will not take very long. Mr. Jenkins has made my life very easy, and as he was giving an excellent talk, I was deleting some slides, which I think he has covered in the heart transplantation talk. So we will just go through the basics of lung transplantation and also cover some aspects of what um, are we doing to increase the donor pool and improve the outcomes. So lung transplantation, the whole journey is a very long and tedious process divided into various stages. So the, there is a proper criteria for referring these patients for the assessment, and then once they are assessed and either added or waiting to be added on the list, there is a pre-transplantation care which they go through, and then there is a process of donor selection, optimization, and matching. And then we'll discuss a little bit about various type of donors, DBD and DCD, how we um, harvest the organ, and then few of my slides will be on ex vivo lung perfusion techniques and how it's going to help in lung transplantation, and then just few words about the techniques. So the indications are quite standard. They haven't changed over the last many years, and basically divided it into suppurative and non-suppurative indications. And in the suppurative one, it is cystic fibrosis, which has got good outcomes. And then there are certain cases of extensive bronchiectasis, which is non-cystic fibrosis related, where we uh, have listed those patients. And then there is obstructive COPD, and then also the COPD related with alpha 1 antitrypsin deficiencies. And then certain patients who have uh, bronchiolitis obliterans, either because of the previous lung transplant or the patients have undergone ARDS for certain reasons, or the patients who have had extensive radiotherapy. The diffuse parenchymal lung disease, idiopathic pulmonary fibrosis has been number one indication now in the United States. And there are cases which we have listed for conditions like Langerhans histiocytosis or lymphangiomyomatosis. And then last but not the least is the pulmonary artery hypertension. And then the contraindications, there are some absolute contraindications and there are certain relative, and the 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 horizon is changing and we are expecting more patients. But these ones, like patient having recent malignancy, which is not skin malignancy, then that's a contraindication. Patients with high BMI, untreated advanced dysfunction of the other organs, uncontrolled extrapulmonary manifestation of a systemic disease, uh, active infection with hepatitis B or C, patient continues to smoke, and the person who is non-compliant and doesn't have good social support, it will be difficult for them to be accepted. There are a lot of criteria as how the patient is accepted on the waiting list. And there is a lung allocation score being used in the United States. We have very clear guidelines here in UK by NHSBT, which are quite comprehensive. The idea basically is to see what is the disease patient has and what is the urgency related to the disease, and also how long the patient has been waiting on the list. And here we divided it into three categories: a normal, routine waiting, and then super urgent or urgent ones. And again, as I said, the criteria are pretty much clearly laid out. But overall, these are the clear indications which fit into those criteria which have been described in this link, which is present there. So anybody who is going into respiratory failure has been admitted with hypercapnias and rapidly declining physiologically the lung functions, getting admitted in the hospitals again and again, and on prolonged course of antibiotics. So these are the conditions where the patients will be referred with end-stage lung disease and considered for lung transplantation. Then there are donor criteria, and the ones which are very clearly laid down by ISHLT are that the donor should be less than 55 years of age, should be non-smoker, should have a clear chest X-ray, the PO2 should be greater than 300 millimeter of mercury on FiO2 of 1.0, have a clear bronchoscopy, so go to each segments and clearly look around, and then size matching is important, and then the patient should be negative for HIV, hepatitis B surface antigen, and hepatitis C antibodies. And mind you, it's only about 20% of these donors which are found to be eligible, and the rest of them are very often rejected because of lung showing some contusion, infection, the patient has aspirated, and then obviously, while being in the intensive care unit, has undergone neurogenic pulmonary edema after the brain death. So to increase the pool, the criteria is being extended. We have started accepting patients greater than 55 years of age, patients who have been smoking with some infiltrates or the PO2 less than 300, or even with secretions. And I'll come to that, how these extended donors can be assessed and the organs used if possible. So to get that number up, so we have a waiting list, which is getting bigger, and we have fewer donors. And as I said, it's only about 20% of these who gets implanted. So we need to optimize these donors, and the journey starts right in the beginning in the ICU. So we should try to reduce the risk to these lungs getting injured by barotrauma or neurogenic pulmonary edema or the ventilatory associated pneumonias. So a very comprehensive physiological support is what we need to give them right in the beginning, with clear fluid restrictions, undertaking gentle therapeutic bronchoscopies, and then recruiting the lungs and keeping the tidal volume between 5 to 8 millimeters mil per kg and PEEP of about 8 to 10 centimeters of water. And then, of course, as Prof. Jenkins just explained, we need to look into the matching, the ABO, the size matching, the actual or virtual cross match. And then if the PRA is high, then we need to treat that. And then, of course, the subjective matching. So how can we increase the number of lung transplants and equally reduce that waiting list and benefit the patients? So one is, as I said, we have an extended donor criteria rather than strictly going by what IHSLT has initially given us. And then manage those donors appropriately, as I have just explained. And also in, go and have a look at the organ rather than be at the end of the telephone and looking or hearing the numbers. So a responsible person should go and have a feel of the organ. And then those marginal donors, or where we are increasingly looking at the DCT, then consider EVLP, which I will just describe in next few slides. And what about single lung transplantation? There are more and more papers coming out where the single lung transplantation in inappropriate cases could be useful, particularly with the patients who have got interstitial lung disease and even some patients with COPD. That obviously will increase the pool of the donors, and more people will be having the lung transplant. And then size matching. So this is something which is now being practiced um, quite often, where a bigger organ can be reduced in size by either on-table lobectomy or undertaking a lung volume reduction type of wedge excision to match the organ. And then there are certain patients who may require some support postoperatively if the lung was compromised or giving the PGDs. Then there are certain papers, particularly from Japan, which has discussed about living donor lobar lung transplant, and we had a few cases or one or two cases here in the UK. But it is a there were quite a number of cases which were done in US as well before 2003 or four, and then this has completely stopped. And I can see it is that risk the donor is put in, that probably is a huge responsibility to take on that donor for donating a lung. Still carries 1 to 2% mortality, although none of the donors who have given um, transplant a lung for the transplant have died. So the basic issues with the lung transplant is that although it is a standard of care for patients with end-stage chronic respiratory failure with good outcomes, improved quality of life, but still the median survival is only 5.8 years. And the lung allografts experience higher rate of early and chronic graft dysfunction compared to other solid organ transplants. And the lower rate of suitable donors, as I said, is barely 20%. And the only factor which we can influence is the preservation of this donor lung. And that's where the ex vivo lung perfusion comes in, the EVLP. And this is just a slide I'm demonstrating where all the organs after DCT, and you look at this, that hardly about 7% of the organs from the lungs are actually transplanted, or even less than that. So the EVLP technique is quite, I would say, intuitively simple. And all you do is that you have the blood going through into the pulmonary artery and then being coming out of the pulmonary veins, either collected in a reservoir or you can have a sort of a receptacle placed over the left atrium to collect it. And then although it can just continue like that, but you do put an oxygenator here to actually get that removal of the CO2 and get proper investigation of what is coming out. So it's basically the subjective assessment of that block. It also gives the opportunity to prolong the cold ischemic time and also that logistics of uh, getting everything prepared and implanting. But more than that, it is the preservation of the lungs at a controlled pressure by giving a perfusate, which is properly warmed proper oncotic pressure, and also an opportunity to give therapeutically antibiotics or other newly tried anti-inflammatory agents into directly into the lung. And as I said, the perfusate which is coming out can be analyzed to see what the gas exchange has been inside. And then we can do a bronchoscopy and we can collect samples, we can clear the secretions. So intuitively, it is something which really helps you to analyze the lung, condition the lung, and then assess it whether this is a good one to be used. So, as I said, careful assessment of the marginal lungs, reconditioning, bronchoscopic toilet, and it's a technique which helps you to manipulate these lungs and give various therapeutic agents at a dose which otherwise would not have been possible. And it improves that logistics. So after you have done the assessment or evaluated what is coming out, these are the ones which probably will not be suitable. The risk where the high risk donor lungs are, where it's a poor PO2, pulmonary edema, atelectasis, and patients who have had a blood transfusion more than 10 units. And almost all the patients after DCD, it will be ideal for these patients to be assessed on the EVLP and then decide whether they can be used or not. And there will be some which can be. And these are the ones which probably we will not be even evaluating. And this is what the contraption looks like, and quite simple. It is. This is the pipes going into the pulmonary artery, and then you, once it is warmed up, then you attach it to the ventilator. And this is another view of that. And this is what Mr. Jenkins was talking about, the heart, the organ care system. And this is one for the lung. That EVLP, which I've just described before, routinely will be sitting in the recipient hospital, and then the organ has to be transported. But this one, the organ goes directly into this machine at the site of the harvest, and then the perfusion and the ventilation starts. And it's quite sophisticated, very expensive machine. And there has been a trial called Inspire trial. I think it was in 2018 or 19, which has shown that there is a benefit. And there is a quite a consequence of that, as more studies come out, that if it indeed is something which improves the PGT or the use of the donors, the marginal donors, then this will create a huge logistical problems, how you are going to be uh, harvesting the organ and using these machines and then bringing it across. It'll be interesting to see what happens with these. So assessing, and I think this is all I've already discussed. And if you have these parameters, that the PO2 is more than 300 millimeter of mercury, airway pressure, pulmonary artery pressure, and if the compliance is improved and chest X-ray is better, then these donor lungs can be utilized. I just included this slide after Mr. Jenkins was talking about the ischemic time. I think that's a bit of advantage in the lungs, that the ischemic time, this is a study where they divided it into four cohorts, and there wasn't much difference. So 6 hours is a sort of a time which we consider is probably suitable for the lungs um, to withstand that sort of ischemia. Now, the operative technique is pretty much similar all over. The only difference is whether you are using any sort of support like cardiopulmonary bypass or ECMO, or you are uh, implanting lungs without support. And I think that's all dependent on the condition of the lungs, the patient, how the patient tolerates the procedure, and how the hemodynamics are, and what the practice is. So basically, it is a double lumen intubation, uh, whatever way you're going to do it, um, unless you have decided right from the beginning on cardiopulmonary bypass, then single lumen intubation could be okay, pulmonary artery line, and no epidural, because if the patient is going to be hypernized. So the medications at induction are pretty standard: methylprednisolone plus minus IVIG, heparin, antibiotics. The approach, again, it varies. We usually carry out most of these procedures through clamshell, but then single lungs can be inserted with the posterolateral thoracotomies. You can have bilateral anterior thoracotomies through fourth or fifth space, and you can connect it together, becomes a clamshell, or sternotomy. Uh, and obviously, with sternotomy, there is a little bit of a struggle on the left side, but something which can be carried out. And as I said, support, it could be off pump, it could be with ECMO, or it could be cardiopulmonary bypass. And then there are certain patients who have awake ECMO as a bridge to transplant and will come with that into the theaters. And that's what you see. It's a fantastic exposure with a clamshell, and you have access to each nook and corner and to the hilum. Explantation is probably at times most time consuming part of the operation, particularly in the patients with the suppurative lung disease, or even in the patients with a COPD. You'll find thinned out lungs, adherent vascular adhesions, and you have to be careful that those bleeders are all taken care of when the explantation is being carried out. So the 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 process is quite straightforward, and universally people carry out the division of the internal pulmonary artery, followed by the inferior pulmonary vein and superior pulmonary vein. And then to have adequate length of the pulmonary artery, just tie the first branch, and then you can divide it further distal to it. And make sure that when you are firing a staple, that the pulmonary artery catheter has been pulled back. And then we normally cut with a knife through the distal main bronchus, and all the bronchial arteries are ideally clipped rather than burned. So make sure that there's not much injury related with the diathermy in that area. The lymph nodes, as you're removing, make sure again that you don't do unnecessary dissection. And most importantly, it is bloodless. Once the organ is in, it becomes very difficult to look at those tiny, whiny bleeders. And then you, as I said, minimum dissect and clip blood vessels, no touch technique, minimal ischemia. And then the bronchus is cut between the rings, and then you just put a stitch and then wait for the donor organ to be put in, and spend some time here, which I'll emphasize that when you are creating a cuff of the pulmonary veins, then make sure you go nicely around the pericardium and you open it all around. That extra length is very important for you to apply a clamp, particularly if you are trying to do it off pump or on ECMO. And check your vascular clamps that you can apply it without taking too much of space, and then how you are going to stitch. So check your vascular clamps, and you'll get used to a particular type and then stick with that. And then the donor block is prepared at the pack table. Normally it'll come transported 90% inflated with FiO to 50%, and is usually comes as a in a 2 bags, and then you open it, take it out, and then prepare the 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 lungs depending on whether it is bilateral sequential or is it going to be a single lung, and you'll have one come like that. The important bit here is particularly if the heart has been harvested, the venous cuff will be very small. So you just need to be very careful when you are preparing that. And if it is too short, then you may have to augment it. And that should be done before you place it in. And then this is important that you cut the bronchus just about half a ring proximal to the secondary carina. And then once the donor bronchus has been opened, that's the end of a full ischemia time. And then you need to take all the precautions to keep the organ cool. So you have it in a cold swab with a cooling jacket or ice around it. And then this is important. Check the orientation. This is take some time to properly orient the lung and goes in, and then once you are satisfied, then the routine 3 anastomotic procedure starts. So the airway is the first one to be stitched, and that is one the stitch we put it in, as I said earlier, and that one then goes from in and out, and then you do continuous membranous suturing, and you can do whatever is okay for you, and there's not much difference in continuous or interrupted sutures. But what we practice is that we start the first layer through the membranous trachea continuously, and then interrupted sutures through the cartilaginous part. All during this procedure, make sure it is tension free. And once it is all done, then you cover it with some thymic fat or some pericardial fat or even pleura. Once the airway has been anastomosed, then it is a pulmonary artery. And this is again crucial here that it is not kinked, it is not too long, because that is important. That spend some time there, and then that the life will be easy, and then take big bites and go all around, and that anastomosis is complete. And this is the one which I always find little difficult, the pulmonary vein anastomosis, and particularly if you are doing it uh, off bypass or an ECMO, then you need to hold that cuff nicely and make sure your vascular clamp is nicely placed around it. And then once that is there, then you again do start your anastomosis from one end and complete it, and then de-airing. So the complications are basically primary graft dysfunction, and this fortunately is not very common, but it is basically ischemia reperfusion injury and occurs within 72 hours. And this will be seen not only in deterioration of the gases of the patient, but also on the chest X-ray. You'll find fluffy shadows, and this is a major problem, but fortunately not very common. Then is the rejection, and about 30% of the patients will have some sort of acute rejection within the first year. And then after that, the main problem which persists is a chronic rejection, which manifests in the form of bronchiolitis obliterans syndrome, where there is a fibrovascular proliferation in the airways, distal airways, and they manifest as reduced flows in the spirometry. Fortunately, airway complication in the form of dehiscence is very rare. Uh, I have not seen this yet, but in terms of dehiscence, if it does occur, then it is a big problem. If it is a small dehiscence, then probably you can put a chest drain in and let the air escape, and as the lung expands, hopefully it will get plugged. But if it is bigger one, then it could be quite catastrophic. Reoperations carry a high mortality in these cases. People have tried to insert covered stents and hoping that granulation tissue will form around it. The stricture, unfortunately, a little bit more common, and surprisingly, I would say, considering that we do not, I think this is the only organ where the systemic blood supply is not restored, and we are relying on the retrograde blood coming through the bronchial veins. But if you look at it, despite that, it is not that common. But when it happens, then it is a big problem. And it could be a real stricture, fibrosis, or it could at times be just malacia. And fibrotic stricture are relatively easy to manage. You gently dilate them. You take out any loose sutures or inflammatory stuff out gently, and it usually responds after a few dilatations done over a period of time. Very, very rarely you may have to insert a stent for a period of time, and then you can remove it. And that is important, that don't leave the stents in for a long time. And as I said, if it is malacia, then it is a bit more difficult to manage, and possibly stents are the way out. And then the infection, and the infections, as we all know, Pseudomonas is a big problem, or Staph aureus, viral infection, CMV, herpes, and various fungal infections, and they are treated appropriately. So the outcomes, looking at this ISHLT report published in 2016, the 30-day mortality is about 4 to 5%, median survival 5.8 years, 5-year survival 54, and the 10-year survival as depicted in this. I understand the results are a little better in 4 years since, but not impressively better. But still, it is good outcomes. So to conclude, ladies and gentlemen, lung transplant is quite well-established treatment modality, standard of care for the end-stage lung disease. It's a very much laborious, multi-stage, multidisciplinary process, but we can achieve good outcomes after this. The good outcomes in terms of survival and quality of life. However, it is still limited by the organ availability, and the current immunosuppression failed to ensure long-term allograft function. And this is something which we probably need to have more work done on. Thank you very much.